Good afternoon, everyone. I'm Shalabh Srivastava from MOH Office of Healthcare Transformation. MOH stands for Ministry of Health Singapore. So, just to introduce, chronic disease is rising globally, and it creates a burden on the healthcare system and also on the personal life of the individuals as well. So this is the main challenge we want to address at Singapore level. So Singapore identifies 23 chronic diseases which they want to address. So multiple chronic conditions, we will be addressing those 23 conditions as we progress over the time in the lifetime of a patient. So opportunity is to predict the disease in advance and to be proactive rather than reactive, which is the traditional healthcare system. So our objective is to, as I said, our objective is to predict 23 chronic conditions simultaneously in future 4 years. And the hypothesis is we are using LSTM and deep neural network. LSTM is a long short-term memory, which is a sequential RNN kind of thing, the recurrent neural network kind of thing. So, and we are using LSTM, combination of LSTM and deep neural network to predict the outcome, multiple outcome at the same time. And also we will be predicting the cost of the patient that will be incurred on the healthcare system after the period of the 4 years. So these are the objective and hypothesis. The data set that we are using is 1.3 million people of Singapore. And the timeline is we are taking care of the 4 years of the lab test and other historical data. And we will be predicting 4 years into the future. So the lab test and everything is taken from 2015 to 2018. And we will be predicting the outcomes in 2022. And so for the longitudinal features, time series consists of the lab test, which is HbA1c, EGFR, etc. Static features, which goes into directly into deep neural network, are patient demographics such as age, gender, ethnicity. Ethnicity is mainly Chinese, Indian, Malay, and others, which are part of the Singapore population. And trained test split is 80 to 20%. Outcomes will be the 23 chronic conditions, as I already told you. So this is the architecture. As you can see over here, this is more of the time series features, which is essentially the lab test. Over the period of 4 years, we are taking the averaging the lab test every month. It's for all the patients every month. Each month of lab tests are not available, so we are imputing using the forward filling or the backward filling. And there is also a model for those patients where certain lab tests are not available. We are using that model to fill in that. It's just a linear Bayesian linear regression model. And for the static features, we are using demographic and duration of the 60 chronic diseases which affects the chronic conditions. So once this time series features goes through LSTM layers, and then those results are concatenated with the these features and fed into the deep neural network. And in the end, these 23 conditions are being predicted. And for the cost, these 23 conditions are actually sigmoidal, which means it's in terms of probability. So these probabilities are being fed into XGBoost, which gives the cost. It's a XGBoost regression model. So main thing that we factored was the preventing the data leakage. So for example, if somebody already has a diabetes, we won't be predicting that thing in the future. So we use this weight system just to mask those particular conditions. And we use PyTorch as a training tool for the deep neural network optimized with ADAM optimization, binary cross entropy loss for the multi-disease outputs. The validation would be 20%, and the validation of all the classification would be evaluated using the ROC, area under the curve of the ROC things. So for the cost, As I just already told, the multiple outputs are being fed into XGBoost. So these are the results for the. Actually, it's not updated. Okay. So sorry for this. It's not updated. So it's around for chronic kidney disease it's 0.92. For lower extremity amputation is 0.91, and for chronic kidney disease pre-dialysis it's around 0.90. So these are the actual values that we got over here. And for ROC, for the cost prediction, the R2 square is around 0.17, which is, if you know about R2 square, R square, so it's not much, but in terms of the cost prediction, because not everyone falls, even though they are high-risk patients, they won't fall sick or go to hospital in every 3 or 4 years. So that's why 0.17 is quite a good number if somebody predicts the cost for the healthcare cost. So in terms of the model interpretation, we perform permutation importance and also the Sharp values. So this is an example for minor lower extremity amputation. And so these are the main driving features, which is driving the for a certain person, if or for a group of people, what are the driving features which are contributing to a lower extremity amputation. And for the population level of segmenting with high sensitivity and high specificity, we use the Jordan's J statistic to determine what would be the threshold for the probability. Okay, so how do we use it? So we are actually planning to introduce our model in the workflow of a clinician, and how it. So if a patient is going to the clinician, based on its past data, there will be some probabilities of different chronic conditions for each, and the dashboard will highlight few top. For example, for this particular patient, the model is highlighting CKD, which is chronic kidney disease, and lower extremity amputation. These are the high-risk patient for these particular, and for lower extremity amputation, these are the features which are contributing to this. So this features actually confirms the doctor, yeah, this is something which is actionable. What things that we need to look for this particular patient. Even if this person is not high risk, some medium risk, that there can be some kind of patient coaching. The patient can be suggested to do some lifestyle changes and all. So mainly this will help in the proactive intervention. So this is one particular scenario where this model is being integrated in the clinical workflow. Another one is where it can be used for the policy implications as well. So the plan is to implement this is one of the examples, that is diabetic foot screening. This is actually which we are planning to implement for. So we will rank. So right now there are a certain group of people who are being called for diabetic foot screening. Right now it's kind of random. All those people who are diabetic are being called, and some people don't follow up. So what we are planning to do is just to rank all those patients and see which ones are the most. Then we prioritize those people. If they are not coming, we follow up more to them. Then those people who are at lower risk, those people can be called, say, in a couple of years, not so quickly as compared to those people are at higher risk. So such kind of planning, policy planning can be changes in the policies can be done using this model. And for the financials, because we are predicting cost, at Singapore level, we have recently implemented capitation model. Capitation model is nothing but where each cluster, Singapore is divided into 3 broad clusters. Each cluster is given certain amount of money, and cluster is now responsible to spend their money. And so now cluster has to focus on value added services. So this model can help in designing the value added services where the cost would be justified for particular kind of services. So these are the main policy implications. So in conclusion, we demonstrated that we have demonstrated that when we are predicting multiple diseases at the same time, it's giving better results as compared to individual predictions. And it also helps in a holistic individual patient care. And so all the AUCs that we got is at very good level, that is around 0.9 to between 0.8 to 0.9. So most of them lies in that. So which is applicable for the population health and patient coaching. And so in future, as I just said, we are thinking of implementing it we are actually in talks to implement this at the clinical settings. For the cost modeling, we are working with clusters to have some policy change and help them how to design their workflows for the value-added services. Those are the two things that are in pipeline right now. Next, these are the main takeaways from the talk. Thank you.
Fantastic. So thank you so much again. If you have any questions in the audience, we've got some time to take some. I see one hand here, so I'm going to walk over here.
Thank you for the excellent talk. Just quick clarification for the data, for the model inputs, the static features are demographics and historical conditions.
Yeah.
These are defined by what, ICD codes?
No, so these are a cluster of ICD codes. So say somebody has diabetes, so it will include E102, all the.
Right, so like, so a grouping of ICD codes or fee codes or something similar to that.
Yes.
And the longitudinal features are essentially vital signs and common lab features, right? That changes over time.
Lab features and also includes weight and if person is smoking or not.
Right. So for this one, then how is this a diagnostic model or prognostic or predictive model? Meaning that, for example, someone with like a hypertension, diabetes, and an EGFR 45, by definition has chronic kidney disease, but maybe it just is not labeled yet with chronic kidney disease. Mm-hmm. So that would be more of a diagnostic model versus someone doesn't have the definition for CKD, but then you're predicting them to develop CKD in the future.
Actually, that is one of the concerns for us. So generally, the way doctor code is primary diagnosis, secondary diagnosis, sometimes secondary diagnosis, while in our EHR, particularly in the Singapore context, this secondary diagnostics get lost somewhere. So what I have observed, for example, even though HbA1c level is trending, but that person is not marked as diabetic. So but mostly things are, it's not primarily meant for diagnostic. It's more like a what will happen in future. But few diagnostic features can also be predicted using this. But mostly, if somebody, all the EGFR values are not correct, is not in good condition, that person is already labeled as CKD. Because CKD is quite a, not so small disease, right?
Hi, thanks for the presentation. It's so practical. I have a question about the AUC and APR. You have really high AUC, but the APR indicator is low. Do you have any concern about it? Because something maybe the
FPR. Yeah. So generally, FPR is 1 minus specificity. So we need low false positive, right? So the lower is better.
Yeah. So with the positive predictive value, it's really low. So I wonder if can I elaborate a little bit more about the prevalence? What about the prevalence of the condition in your study? Because it may affect the AUC. Like if you have a low prevalence, then maybe the AUC is not a good indicator to show that the model is the best one.
Yeah, so for the low prevalence conditions like low extremity amputation, which is very relatively rare condition, during the entropy loss, there is something called weight. We have adjusted those weights, which is a ratio of total positive to total negative value. So that is adjusted in the loss model.
My question was also kind of around like how much you're able to predict new disease, like new chronic diseases versus things that are kind of like known comorbidities with like a diabetes diagnosis. And then how, I guess you also talked about how this could be used to kind of survey and predict like what resources might need to be allocated to a certain place. How does your prediction of the disease compare to like just the incidence of it already? Like how much it was prevalent in the community?
Okay, so if somebody already has a particular disease, we are not predicting it because it's a chronic condition. So we assume that that person will have this thing for the whole life. So we are not predicting this. Everything that we are predicting is the new occurrence of the disease. And
are they like known comorbidities? So it's like you have diabetes, then like an amputation could be something that's like known, could
that's
like
new, new one,
widely associated, strongly associated with a diabetic condition. That's
yeah, you're correct. Yeah, and so because of so how all the diseases play out, that affects the what the cost will be 4 years down the line. So that's how we are predicting the cost. And you see that the R2 square is never very good. It's around 0.17. But it's an indicative value. 0.17 is for per individual basis. But if you take the cohort of say 1,000 people, then things are make more sense. So things average out, and the prediction is at the mass level is pretty good as compared to individual level.
Hi, thank you for the talk. So I had a question related to the R square only. So how would you like explain the low R square?
Actually, if you go with all the standards, even whoever works in the prediction of cost, so the best of the R square is around 0.2 or something like that. Most of even in US conditions, I think they segment HCC has their R square at around 0.15 to 0.2. So it's pretty much there, and they use it for the commercial purpose as well. And as I said, this is for individual. We never, when we are doing at the population level, we do not care about how it's affecting an individual, because cost, if a person has some incurring cost, that has to be managed. But at the population level, how things has to be designed, that's of more concern. So if you take a lot of say 5,000 people or 1,000 people, so the difference is not that much.
Thank you.